infectious disease. So initially we have the important segment of cardiology, and none other than two of the brightest minds in the critical care circuit of India. In fact, uh, I'm banking my future on both of them, right? And they're not uh, uh, sort of future star. They're the present star itself with an excellent future. Dr. Niranjan Panigrahi and Dr. Swarna Deepak. In fact, Swarna is one of my closest person. I like him on that way. Not that I like Niranjan any less, right? So, but Swarna and we touch in a different day, right? From the very beginning, for almost 8 9 years itself. So I would request both of them to moderate and guide the session, entire session, and we have, just like the last time, we would be discussing each topic and subtopic at one go for 8 minutes, and then for 2 minutes, the moderator and guide, Dr. Swarna and Dr. Niranjan, will give you the overview as well as some of the tidbits if anything has been missed by the presenting faculty, and some last minutes tips and tricks for the candidates. And then this entirety would be based on that to uh, how to score well in the exams itself. And my sincere request to the presenting faculty is that these guys are all very well prepped. This is what we are doing, a last minute revision, as well as giving them the idea that how to uh, write the question in 15 16 minutes time, right? So that's the overall idea, that how well we should go. So over to you, Niranjan and Swarna. And I am here all through all the 4 hours, 24 hours itself, and if required I will chip in. Thank you.
Thank you, sir. I think the first point is myself thanking you for giving us the opportunity. Wonderful program, especially targeting the exam going student for their benefit. I think the time is quite vital here. So without much ado, I'll introduce the first speaker, Dr. Kirtana. When Arindam sir asked me and Niranjan, who is your best students? So I think first Kirtana, Saich and Melito, three of us came to us, and very sincere, very hardworking, and they are one of the best example for the how the student should be. So Kirtana is presently a consultant in critical care from Sindhu Hospital, Hyderabad. Kirtana, over to you. Please start.
Yes, sir. Good evening, everyone. Thank you, sir, for giving me this opportunity to talk on this platform. So starting off with acute coronary syndrome. So these were the questions that I had to stress more upon. Sir, I'm not able to move my slides. Types. Type 1 is because of a coronary atherothrombosis causing a partial or a complete thrombosis. Type 2 is based because of a supply-demand mismatch. And type 3 is sudden cardiac death secondary, presumed to be because of an ischemic etiology. Type 4 is peri and post-PCI MI. And type 5 is peri-CABG MI. So coming to the diagnosis, ECG, biomarkers, and echo. So this is what we all have to probably write in the exam. That is new onset ST segment elevation more than 1 mm in more than 2 anatomically contiguous leads at the J point in all other leads other than V2 and V3. But in V2 and V3, more than 2 mm in men more than 40 years of age and more than 2.5 mm in men less than 40 years of age. And in women, irrespective of the age, more than 1.5 mm in V2 and V3. And it's important to remember the coronary artery territories based on the ECG. Then biomarkers. We all know that the biomarkers, once there's a myocardial injury, they spill over into the interstitium, initially absorbed by the lymphatic system. And when that's overwhelmed, it spills over into the venous system and detected in the blood. So the earliest to rise and fall is myoglobin, but not very specific. And followed by CKMB, which rises and falls before the troponin. And troponin remains elevated for around 7 to 10 days. So a reinfarction is very difficult to detect with troponin. So CKMB can help us at that time. Then echocardiographic diagnosis, this is just an image to show us the different views of the echo and focusing on the territories. So the red is the LAD territory. This is in the plaques, the 4-chamber, the 2-chamber and the short axis view, and inferior wall supplied by LCX and RCA. So we just have to remember these territories when we do a bedside echo. Risk stratification. Why do we have to risk stratify patients? First, to prognosticate the family, and second, we also have to guide therapeutic interventions based on the risk stratification. So we have two scoring systems. One is the GRACE and the second is the TIMI. So they consider several clinical factors like age, Killip class, the blood pressure, whether cardiac arrest occurred or not, and the degree of the ST segment elevation or depression, and various factors that are listed here. So the higher the score, the more risk of adverse events or even mortality. And gray score has a cutoff of around 140. So beyond that is high risk, and a TIMI score cutoff of more than 5 for high risk. So standard medical therapy, mainly oxygen therapy, analgesics, antiplatelet therapy, parenteral anticoagulation, lipid management, beta blocker therapy, and RAA system inhibitors. So coming to the medical therapies, we all know that supplementation of oxygen only to the patient who is hypoxic, that is with a saturation of less than 90%. And it's also counterproductive if we administer oxygen to patients who are not hypoxic with a saturation of more than 90. It can increase the infarct size. And this is supported by evidence, that is AVOID trial and the DETOX AMI trial. And analgesia control is also a very important thing to do in management of ACS. So we can use sublingual or IV NTG, but keep in mind when you use it in patients with hemodynamic instability or hypotension. And we can use opioids like morphine and fentanyl in patients where all other therapies like anti-ischemic medications have failed to control the pain. Then we can go ahead with opioid therapy. So antiplatelet and statin therapy, this is a class 1 recommendation based on the latest AHA guidelines. So we know the doses: aspirin loading followed by the maintenance, clopidogrel, prasugrel, and ticagrelor. And we also have to combine it with the high intensity atorvastatin and rosuvastatin statin therapy based on the appropriate doses. Then coming to parenteral anticoagulation, usage of unfractionated heparin. The loading dose of around 60 to 80 international units per kg, followed by a maintenance of 12 to 18 international units per kg per hour, and target an either ACT or an APTT. Then other drugs that can be used are bivalirudin and enoxaparin, and these doses can be seen later on. Then beta blocker therapy. Yes, it's a class 1 recommendation to use beta blocker therapy in patients who present with ACS with no contraindications to beta blocker therapy, who present early. So it is shown to reduce the risk of reinfarction and ventricular arrhythmias. And RAS system inhibitors also has a class 1 recommendation to use in patients with LV dysfunction with an EF less than 40% and with comorbidities like hypertension and diabetes. And also if the patient has symptoms of heart failure, then it's recommended to add an MRA antagonist. So coming to the reperfusion strategies, it's a class 1 recommendation for early reperfusion in STEMI. So when a patient comes to a PCI capable center with symptoms of ischemia, so an ECG has to be done within 10 minutes, diagnosis of STEMI, and directly activate the cath lab and shift the patient directly to the cath lab. And the door to the balloon time is around less than 90 minutes or less than 120 minutes if the patient has been referred from another center. Next, if the patient arrives at a non-PCI center, do an ECG within 10 minutes, diagnose a STEMI, and then decide your transport is going to take less than 120 minutes or more than 120 minutes. If it is taking less than 120 minutes, shift the patient immediately to a PCI capable center and go ahead with a primary PCI. If not, go ahead with a thrombolysis and then consider shifting the patient for a check angiography post thrombolysis. So the doses of fibrinolytic therapy, the most commonly that we use is altiplase and tenecteplase. The doses are 15 milligram IV bolus followed by a infusion of 0.75 mg per kg over 30 minutes and 0.5 mg per kg over 60 minutes. And 1080 place is a weight-based therapy. So less than 60 is 30 and as follows here. So it's very important to also consider the absolute and the relative contraindications before considering fibrinolytic therapy. Then coming to the NSTEMI ACS, whether to go with a routine invasive or a selective invasive therapy. So if a patient has a high risk or an intermediate risk NSTEMI ACS, go ahead with a routine invasive strategy. Take the patient up for a PCI or a CABG if PCI is not possible, or medical therapy alone based on our non-invasive risk stratifications. So if the patient is a low risk NSTEMI, go ahead with a selective invasive strategy. So then further stratify the patient based on non-invasive risk stratification, that is a stress echo or a CT coronary angio. Or if the patient has recurrent ischemic symptoms, then go ahead with a routine invasive strategy. If not, a selective invasive strategy with medical therapy alone. So what about the choice? So if the patient is unstable, high risk patient who is in shock or symptoms of heart failure with pulmonary edema, refractory angina, or with electrical instability with VTVF, directly go ahead with a immediate invasive strategy. And if the patient has a high risk NSTEMI, that is with a gray score of more than 140 and steeply rising troponin values and ongoing dynamic STT changes, then go ahead with a routine invasive. If the patient has an intermediate risk NSTEMI with a gray score of 109 to 140 and absence of ongoing ischemic symptoms, stable or downtrending troponin values, consider a routine invasive. If the patient is a lower risk patient with low grays, low TIMI, no ongoing symptoms, low troponin values, and no dynamic STT changes, then consider a routine invasive or a selective invasive based on our non-invasive risk stratifications. Yes, sir.
Yeah. Thank you, Kirtana. I think very well summarized about the topic of acute coronary syndrome. For the students, I think most of them was covered in the brief presentation. One thing is make sure that you read about the role of mechanical circulatory devices, the latest trials which are being done. In fact, the role of beta blockers are also being questioned, especially with the patients who has a preserved LV ejection fraction with comorbidities. So before the exam, just make sure you brush it off, and those times, remember those times specifically. The examiner may ask you.
What is the new evidence that has come that with a preserved ejection fraction, beta blocker may be detrimental, right?
Yes, sir. Yes, sir.
Very new study that had come.
Yes, especially the duration is questionable, sir. How much is duration also is questionable.
Right.
And 1 year.
But I think the beta blocker still holds place for people with low ejection fraction. So
Yes,
that
yes.
is still there.
Less than 40, still it is the standard of care, sir.
And the other thing I would request both you and Niranjan that once this is over, there are two things we are doing. We would be distributing or posting the presentation so that they can look into it. And I would ask you to finalize, revise if required. Mostly this is a fantastic presentation. And secondly, another additional 10 questions if you can recommend, which could be useful. Just now you said that mechanical circulatory device like that. Additional, you are presenting 10 to 12 questions. Additional 10, 12 questions which the candidates would read would be important for the exams itself. Please
Done.
carry on.
Yeah. So, Kirtana, I think before move on, another one thing the student should remember is the role of previously what we used to think is we'll handle the culprit artery first and we'll go to the non-culprit arteries later. But now the present evidence says that handle all the both culprit and non-culprit in the same setting, if I'm correct. So having said that, please go to the next topic.
Moving on to pulmonary embolism. So the first, the clinical predisposing factors for VTE and PE are they are strong risk factors, moderate and weak risk factors, and having an odds ratio of more than 10 for strong risk factors and so on. So just to list a few, the most important ones are patients who undergo, hip and knee replacement, major trauma, and previous VT with spinal cord injuries, and in ICU, central line related, intravenous catheters, leads related, heart failure, respiratory failure, and oral contraceptive therapies. And one very important is cancer. Most probably the GI malignancies have the highest risk, followed by the hematological malignancies. And other low risk factors like bed rest more than 3 days, diabetes, hypertension, or immobility, and minor surgeries. Then pathophysiology. So the RV failure due to the acute pressure overload is considered the primary cause of death in severe PE. So the pulmonary artery pressure increases to more than 30 to 50% of the total cross-sectional area of the pulmonary artery bed is occluded by the thromboemboli. If more than this is occluded, then the pulmonary artery pressure increases. And further, there is an increase in the thromboxane A2 serotonin, which contributes to the increase in the PVR, which leads to the increase in the afterload, further RV dilatation, tricuspid insufficiency, increase in the RV wall tension, oxygen demand of the RV ischemia, decrease in the RV contractility, further decrease in the RV output, leading to a decrease in the LV output, low cardiac output, low blood pressure, and low coronary perfusion pressures of the RV. So finally leading to a decrease in the oxygen delivery to the RV. So leads to obstructive shock and death. So this is the spiral of death in acute pulmonary embolism. Next, what about the pre-test probability scores? So this is the first one, the revised Geneva prediction rule. So the simplified versions have been introduced for easy bedside calculation. So a 3-level scoring system and a 2-level scoring system. So P unlikely if the score is 0 to 2 and likely if it is more than 3. So the factors that they consider are previous P, tachycardia, a previous surgery within the past 1 month, hemoptysis, cancer, unilateral limb pain, or pain on deep venous palpation, and age more than 65 years. And the Wells prediction score more or less includes the same clinical factors, also has a simplified version, but it does not have a 3-level scoring system. It has a 2-level scoring system. So P unlikely if the score is 0 to 1 and likely if the score is more than 2. Then the risk stratification, like what about the mortality? So that we assess using the pulmonary embolism severity index or the PESI. So they have introduced a simplified version which considers age more than 80 years, cancer, heart failure, pulmonary disease, tachycardia, hypotension, and hypoxia. So these factors are considered, and if the score is 0, then the 30-day mortality risk is about 1%, and if the score is more than 1 point, then the mortality risk is about 10%. Then coming to the diagnosis, what about D-dimer? What is the value or role of D-dimer? So we all know that it has a high negative predictive value. So it's not really useful for confirmation of PE as it's elevated in most of our ICU patients, in patients with cancer, pregnancy, all the hospitalized patients with severe infections, inflammatory diseases. So the latest guidelines had introduced this age-adjusted cutoffs, that is age into 10 microgram per liter for patients more than 50 years of age. So usage of this age-adjusted cutoff instead of our standard 500 microgram per liter cutoff, it increased the number of the patients in whom PE could be excluded from a rate of 6.4 to 30% of the patients. So, and point of care D-dimer assays should only be used in patients with a low pre-test probability. Then coming to our invasive diagnostic modalities. So CTPA, it's the most readily available, round-the-clock available modality, excellent accuracy, strong validation in all the studies, and low rate of inconclusive results. And if P is not, if P is excluded, it will also give us an alternative diagnosis. But the limitations of this is high radiation exposure, and it cannot be used in patients with radiocontrast allergy or in patients with severe renal failure or pregnant and breastfeeding women. So in this population, you can consider diagnostics like lung scintigraphy, VQ scan and VQ SPECT. But these studies can be used more preferably only for the low risk PE patients, and the gold standard is pulmonary angiography, but it has the highest radiation exposure. Then coming to the echocardiographic signs of RV dysfunction. So this is, I think, a very familiar picture that all of us are exposed to. So first is the RV dilatation in the plaques view, then McConnell sign and our RV to LV ratio more than 1 in our 4-chamber view. And this is the typical D sign because of the RV overload that is causing the shift of the interventricular septum to the towards the LV in short axis view, and IVC dilated and plethoric, and the 60-60 sign. So how do we get this? So you do a short axis view at the level of the aorta, put the pulse wave Doppler and check the pulmonary acceleration time. It should be less than 60 milliseconds. And do a 4-chamber view, put a pulse wave Doppler at the tricuspid valve and check for the tricuspid gradient. If it is less than 60 mmHg, so that is the 60-60 sign, which is specific for PE. Or you can find a free floating thrombus in the RV or RA, and TAPSE less than 16, which suggests RV dysfunction. And in tissue Doppler imaging, if the peak systolic velocity of the tricuspid annulus is less than 9.5, so these signs are all suggestive of RV dysfunction in echo. Next, so the initial management of any patient with PE is initial stabilization with oxygen. That is the respiratory support, oxygen supplementation. If the patient is tachypnic, you can also support them with NIV, HFNC. And next is the hemodynamic support and anticoagulation therapy. So in hemodynamic support, we mainly have to concentrate on RV support, like management of RV failure. So you load the patients, you keep a euvolemic status in these patients, and to improve the RV inotropy, to improve the systemic blood pressure, and to restore the coronary, perfusion gradient, and to lower the filling pressures, we prefer vasopressor and inotropic support together, because only dobutamine could cause hypotension. So use both. Then mechanical circulatory support gives us both cardiovascular and respiratory support, and this can be preferred in patients who have a cardiac arrest, hemodynamic instability, persistent shock, refractory shock, or patients who also are being taken up for pulmonary embolectomy. Then what is hemodynamic instability based on the guidelines? So either the patient comes with a cardiac arrest that requires resuscitation, or obstructive shock with a systolic blood pressure of less than 90, requiring vasopressors to maintain a blood pressure more than 90, despite an adequate filling status, with end organ hypoperfusion signs. Or the patient has persistent hypotension, like a blood pressure of less than 90, or the drop more than 40, lasting more than 15 minutes, and not caused by any other cause. So then, if a patient comes with hemodynamic instability, what is the algorithm? So initially, you do a bedside transthoracic echo. If there are signs of RV dysfunction, yes, then if possible and if available, do a CTPA. If the CTPA is positive, treat the patient as a high risk. If the CTPA is negative, look for alternate causes of shock. If the CTPA is not available, you can directly go for a treatment if there are signs of RV dysfunction in echo in a hemodynamically unstable patient. Next, if the patient is hemodynamically stable, then assess the clinical probability based on our prediction rules. Then if there is high clinical probability, go ahead with a CTPA. If it is positive, treat the patient. If not, look for alternate explanations for the symptoms. Next, if the patient has a low or an intermediate clinical probability, or the PE is unlikely, first do a D-dimer testing. If that's positive, go ahead with a CTPA. And if PE is confirmed, go ahead with the treatment. If not, look for alternate causes of thing or no treatment for the PE. So this is just to summarize the previous 2 slides. So if it's a case of high risk PE or an intermediate risk PE with hemodynamic instability, based on the bleeding risk of the patient, you go ahead with a thrombolysis or a catheter-directed thrombolysis, aspiration thrombectomy, or a surgical embolectomy. But if the patient has refractory shock, put the patient on VA ECMO first, then consider anticoagulation monitoring or a surgical embolectomy or catheter-based therapies. Next, coming to the anticoagulation, as discussed in ACS, the doses are similar here. Enoxaparin at a dose of 1 milligram per kg BD and low molecular weight. We can also use NOACs like apixaban, rivaroxaban, and edoxaban, and also vitamin K antagonist. And if the patient has a creatinine clearance less than 30, then consider your unfractionated heparin in the doses as previously described. Then what about reperfusion therapy? So either you go ahead with a systemic thrombolysis or you do a percutaneous catheter-directed treatment, or go ahead with a surgical embolectomy. So when do we really do a percutaneous catheter-directed treatment? If the patient is not fit for a systemic thrombolysis, you can go do a percutaneous therapy with a lower dose of the thrombolytic agent that can be used, around 1/10 of the dose. And if the patient is a high risk, put the patient on VA ECMO and you can take the patient up for surgical embolectomy. Then doses for systemic thrombolysis is you altiplase 100 milligrams over 2 hours and 0.6 milligram over 15 minutes, followed by the remaining dose should be administered. And also here, consider your contraindications to the fibrinolysis, that is the absolute and the relative. And one more point I would like to add here is based on the PITO trial, they stated that when they tried systemic thrombolysis in intermediate risk patients, they found a high risk of intracranial and extracranial hemorrhage. Hence, in intermediate risk patient, each case has to be individualized. The risk and benefit of thrombolysis or percutaneous therapy or systemic anticoagulation has to be taken. Then what about the prognostic assessment of P? So they've divided it as high risk, intermediate high risk, and intermediate low risk, and low risk. This is to assess the 30-day mortality. So high risk patients are patients who have a hemodynamic instability, who have a simplified PESI of more than 1, who have signs of RV dysfunction on echo and CTPA, along with elevated cardiac troponin levels. So intermediate high risk patients are very similar to the high risk patients, except that they are not hemodynamically unstable. And intermediate low, they only have either RV dysfunction or elevated troponins with a simplified PESI of more than 1. Yes, sir.
Yeah, thank you for the presentation, Geetana. I think quite an important topic, especially one of the favorite for the exam going students. Any case, right from the stroke to sepsis, anything can have a PE, and the discussion may go towards the PE, the management part. I think Neeru will be telling about the role of ECMO, VA, ECMO, the mechanical device. More and more, the evidence, most of the latest trials are pointing towards the catheter-directed thrombosis, large bore thrombectomy. In fact, the latest, all the trials are most on those kind of concepts. I would request all the students to go through the latest trials. The standard reading should be there, like how to prognosticate, how to score them. But the Niranjan, anything about the thrombectomies and the mechanical devices?
Yeah. So, students like SCS and pulmonary embolism, of course, these are like not optional topics. These are like clear pass, clear fail. So, examiner will not excuse any areas. In acute coronary syndrome, small part in the management. Of course, more and more questions you will ask in the diagnosing complicated patient in ICU. How do you diagnose? Those things will be asked. You need to be prepared. In the management part, suppose the patient goes into acute like the cardiogenic shock, so the mechanical circulatory support, there are more and more evidence in the favor, so you need to be prepared. Same thing in pulmonary embolism. Again, there are diagnostic dilemmas like intermediate risk patients. So she told the PITHOS trial. So there is again whether you will go for a thrombolysis or you will wait. That depends upon again the three things. One is the damage marker or dysfunction markers. Okay, that means you have to see that HS drop by, you have to see the 2D echo, the LV function. Okay, PITHOS trial has tried to answer. Please go through. That is a very favorite area of the examiner. There is again recent evidence in hemodynamically unstable patient. There is a recommendation of mechanical circulatory support in pulmonary embolism, and there is more evidence for the catheter-directed thrombolysis again. So favorite areas need to be fully prepared.
And all of you should read about the newer oral anticoagulants, DOACs, because of the because this discussion also.
More, yeah, one more area they can ask. Okay, so what will okay? We regularly being in touch with, sometimes we forget to focus on that area. Don't forget, at times that is the favorite area of examiner. So what all anticoagulants you will give, or when you will ask them for follow-up, what is the probability again he will like a pulmonary embolism. Okay, you need to be thorough. There is a guideline in from American Thoracic Society. Hardly it is a 2-page guideline. Everyone mandatory, please go through this. So specifically on the embolism, how many days the anticoagulant should be given.
We'll move to the next topic.
Yeah.
Okay.
Just to both of you, Niranjan and Swarna. So this is, we have a separate domain for success P, where we will, during the practicals, we will discuss the case and others. So there we would be discussing all that, what could be the possible next question, next domain that they can discuss and all others. Here, whatever you are guiding them would be on the basis of theory questions that could come. So I would request you to stick to the probable theory question. So one question would be that
All the peerless.
just as how the examiner's discussion flow. Okay, thank you.
Kirtana, please.
Yes, sir. So moving on to mechanical circulatory support devices. So these are devices which unload the left ventricle or the right ventricle or both biventricular support in cases of cardiac failure or cardiogenic shock. So what are the indications of these devices? So cases of acute MI, complications of acute MI like VSD, ischemic MR, acute and chronic heart failure, RV failure, secondary to RV MI, and myocarditis, refractory cardiac arrest, refractory arrhythmias, post cardiotomy shock, severe valvular heart diseases, and post transplant in case of primary graft dysfunction, stress cardiomyopathy, peripartum cardiomyopathy, and mainly drug intoxication secondary to calcium channel beta blocker overdose, and high risk interventions like PCI and ventricular tachycardia ablation. So we can use these devices in these indications. So they can be used as a bridge to recovery, like in cases of potential reversible causes like acute MI, myocarditis, post cardiotomy, and as a bridge to bridge, like a temporary device is continued as a bridge to a long-term VAD, or as a bridge to transplant, like when patients are eligible for a transplant, or a bridge to decision when we don't know that the potential for the transplant or the recovery is unclear, or as a destination therapy when recovery or transplant both are not feasible. So you can classify them like this as short-term and long-term based on the duration of the therapy. So short-term are devices that support the LV, that support the RV, and that support both ventricles, like biventricular support. So those that support the LV are IBP, Impella, Tandem Heart, CentriMag, Rotaflow. Those that support the RV are Impella, RP, Tandem Heart, and Protect Duo cannulas. And biventricular support is VA ECMO. And long-term devices like first generation left ventricular assist devices, second generation like HeartMate 2 and Jarvik 2000, third generation HeartMate 3 hardware, and biventricular support using total artificial heart. So these are the devices we'll be discussing. We'll be discussing about IABP and Impera today. So this is just a chart to show you like how much support are these devices really offering. So IABP improves the cardiac output by around 1 liter. Our Impella 2.5, as the name suggests, it improves cardiac output by about 2.5 liters. Impella CP up to 3.5, Impella 5 up to 5 liters, and VA ECMO can offer the maximum support up to 5 to 7 liters of cardiac output. So IBP. So intra-aortic balloon pump. So it uses a pump, a polyethylene balloon, and the counter pulsations. That is, it inflates during the diastole and deflates during systole. And this sits in the descending aorta. And the volume of this balloon is around 30 to 50 ml. And they use helium to inflate and inflate this balloon, as it is an inert gas. And even if there is a rupture, chances of embolism is low. So what are the goals of therapy? Mainly two things that you have to write in the exam: systolic unloading and diastolic augmentation. Okay, so mainly to enhance coronary and systemic perfusion pressures, to reduce the LV wall stress, the LV filling pressures, and myocardial oxygen consumption. So the two main components of this device are the double lumen 7.5 or 8 French catheter and the pump console to control the balloon. So access site, most commonly we use femoral, but axillary and subclavian can also be used. And insertion, you use a Seldinger technique to insert a guide wire, the introducer sheath, and the IABP. And the tip of the IABP should lie just below the opening or the ostium of the left subclavian artery. Then what are the contraindications? Severe aortic regurgitation, severe peripheral vascular disease with plaques in the aorta, an aortic dissection, or an aortic stent. Next, coming to the timing or the triggers. So the IABP inflates during the diastole, that is at the peak of the T wave, and it deflates or inflates at the dicrotic notch, and it deflates just before the systole, that is peak of the R wave. And this is the balloon inflation interval. So it has a pressure trigger, a ECG trigger, and a trigger after ventricular spikes. Then what are the hemodynamic effects of IBP support? As previously I've mentioned, it's systolic unloading and diastolic augmentation. Okay, it mainly increases the aortic pressure during the isovolumetric LV relaxation, and it unloads. The sudden deflation of the balloon during the systole, just before the systole, creates a sudden decrease in the afterload and improves the cardiac output. So this is the IABP waveform. This is the unassisted waveform, and this is the assisted one. This is a 1:2 augmentation. This is the unassisted diastolic, unassisted systolic pressure. This is the augmented diastolic pressure. It's inflating, and this is the augmented diastolic pressure. And this is the assisted end diastolic pressure. And to assess whether the augmentation is effective or not, the assisted end diastolic pressure should always be lower than the unassisted diastolic pressure. And this is the assisted systolic pressure, which is lower than the unassisted systolic pressure. And how do we confirm the tip of the IBP in the X-ray? So it is located just below the aortic arch or above the carina, 2 centimeters above the carina to the left side, and just below the opening of the subclavian artery. And this is the IBP monitor, the ECG trace for the trigger, and this is a 1:1 augmentation. Every beat is being augmented, and these are the pressures that we mainly monitor. That is the augmented diastolic blood pressure, and this is the balloon inflation graph. So this is a very important thing that we all have to concentrate on: the timing errors, like early inflation, late inflation, or early deflation and late deflation. So if the balloon inflates early and deflates late, it is counterproductive. It means that it's inflating during the systole of the cardiac cycle. So the cardiac output is decreasing, is going to decrease. So the point of placing the IABP is not served. Then if it is inflated late and deflated early, the augmentation is not sufficient. So we'll have to put the IABP on 1:1, 1:2, and check the inflation interval. Or if we are not well versed with this, we can put it on an auto mode. Then maintenance. So we have to anticoagulate the patient to reduce the thrombotic complications. And what do we monitor? So patient related. Every hour we monitor the peripheral pulses, look for limb discoloration, and we monitor the augmented diastolic blood pressure. And it's preferable not to flex the hip. And if you want to give a head up, give a full bed head up. And device related, the helium gas and daily chest x-rays to see check for any device migration. And lab values that have to be monitored are the hemoglobin, because IABP, it can lead to hemolysis and probably altered renal function test leading to AKI and elevated LDH in case of hemolysis. And consumption, the device related destruction of the platelets can cause thrombocytopenia. And as the patient is on anticoagulation, monitor the ACT or the APTT during therapy. So how do we wean IABP? So once the patient is hemodynamically stable after 12 to 24 hours for 12 to 24 hours and on minimal vasopressor support, the 1:1 IABP support is reduced to 1:2 and 1:3. And also we decrease the augmentation from 100% to 75 to 50. And then if the patient is tolerating, hemodynamically fine, ABGs are fine, then we remove the IABP. So what are the complications? Again, patient device and the lab related. So the patient can have bleeding, hematomas at the site, limb ischemias, hemolysis, AKI, and dissection of the aorta. And device related, the balloon can rupture and air embolism can occur. And the lab are just the reflection of all the complications that occur in the patient. So what is the evidence? Initially, the shock trial showed that in patients with acute MI and cardiogenic shock undergoing PCI, if the patients were put on IABP, it had an improved mortality. But in IABP shock 2 trial, they showed that acute MI patients with cardiogenic shock, does IABP or medical therapy alone improve the mortality? And they found that the all-cause mortality at 30 days was not very different. So the use of IABP versus the conventional therapy did not really reduce the mortality. Moving on to Impella, it's a percutaneous transvalvular microaxial flow pump based on the working principle of a rotating Archimedes screw within a hollow pipe. So what does it do? It pumps the blood from the LV to the ascending aorta by traversing the aortic valve. Or if it is supporting the RV, then it takes blood from the IVC to the pulmonary artery, traversing the tricuspid and the pulmonary valves. So the left heart support are Impella 2.5, Impella CP, and Impella 5, and Impella RP is for the right heart support. So the insertion, this can be inserted percutaneously or surgically under combined fluoroscopic or echocardiographic guidance. And Impella 2.5 and CP can be placed subcutaneously, percutaneously via the femoral artery. But Impella 5 has to be placed surgically through the femoral artery, subclavian artery, or the axillary artery over a graft. And Impella RP is inserted through the femoral vein. So this is how the motor is. This is the outlet and this is the inlet. So this part is into the LV cavity. So it sucks the blood from the LV, unloads the LV and pumps the blood into the ascending aorta. So this is the outlet. And this is the pump area. So how do you confirm the position of this? So this is where we have inserted it into the aorta, goes, and this is the outlet in the ascending aorta, and this is the inlet, that is the LV cavity. And this can also be confirmed by our bedside echo in the plaques view. You can see the inlet here and the outlet in the aorta. So what are the hemodynamic effects? So this also unloads the LV through reduction of the left ventricular end-diastolic pressure and the end-diastolic volume. It reduces the pulmonary capillary wedge pressure, RV afterload, and it increases the MAP cardiac output and the cardiac power output. And it also causes an improvement in the coronary blood flow, even in the ischemic territory, due to concomitant increase in the MAP and decreased myocardial wall tension. So it causes an improved overall increase in the blood pressure, which further enhances the coronary blood flow. So same absolute contraindications are if the patient has an LV thrombus that can lead to systemic thromboembolism. So that has to be looked into, or a mechanical aortic valve. And relative contraindications, patients with severe AR, aortic stenosis, or a small LV cavity, HOCM patients, or cardiac amyloidosis, post-MI VSD patients, or patients who have a hemolytic preponderance. Sickle cell or thalassemia patients, then ascending aortic arch aneurysm or severe peripheral vascular diseases. So what are the complications? So it can lead to limb ischemia, vascular injury, bleeding, hemolysis, and the rate of hemolysis is higher with Impella compared to the IBP, and hemolysis induced AKI. There could also be a device migration, ventricular arrhythmias, LV perforation, tamponade, or acute mitral and aortic valve regurgitations, and thromboembolic complications. So the evidence, this is the danger shock trial. The Danish and the German group conducted this trial. So they wanted to see whether in patients with STEMI cardiogenic shock, usage of this microaxial flow pump, Impella CP, did it compared to the standard care, did it reduce death at 180 days? So they inserted Impella and it was run for 48 hours. Median duration was around 59, but still in the intervention group, 8 of them did not receive the device. And in the standard care, no Impella was used. Impella wasn't used, and there were 3 crossovers into the intervention arm. So what did they find? They said that use of the microaxial flow pumps in STEMI cardiogenic shock led to lower risk of death at 180 days. Yes, sir.
Thank you, Kirtana.
Yes.
So, guys, nothing more to add. Now, in the mechanical circulatory support verticals, is that like over time there are more and more evidence. Correctly see place the danger shock trial very recently published. So everyone please go through this thing. In fact, this is the first trial which came in favor of Impella. So there are so many people are like tempted. Okay, that's one thing. So these are the two like straightforward questions you have to be prepared.
Kirtana, we are running short of time, so
Yes, sir. I'll
request.
hurry up.
Thank you.
So moving on to Takotsubo cardiomyopathy. So Takotsubo syndrome is an acute myocardial syndrome characterized by a peculiar transient cardiac wall motility abnormality, characteristically the apical ballooning that is seen without impairment of the coronary arteries. And they can present with severe cardiac failure, and it's typically presented following an emotional stress or acute severe pathologies like a systemic disease like subarachnoid hemorrhage, stroke, sepsis, cancer, and where it's associated with an increased activation of the sympathetic nervous system. So the symptoms mimic that of acute MI, and the manifestations are varied, such as chest pain, ECG abnormalities, and also increase in the troponins and heart failure. So they could be classified as primary and secondary. Primary is one following emotional stress, and secondary is one following physical stress or trauma. So pathophysiology, there are multiple theories that have been suggested, but the most accepted is the adrenergic hypothesis. So any stress factor, physical, emotional, mental, anything, stimulates the hypothalamic, pituitary, and adrenal axis. That leads to the increase in the catecholamine secretion, which can cause vasospastic ischemia and microvascular damage in the coronaries, or inflammation-related cardiac dysfunction, or the beta receptors. So why is this typical apical ballooning seen? There is the highest density of the beta receptors in the apical region. Hence, they respond to this increased catecholamine levels in the body, and the GI, the inhibitory pathway is activated, and negative inotropic effect is seen. Or the catecholamines can cause a direct myocardial toxicity. So ECG features, they can present typically like a STEMI with ST elevation, depressions, bundle branch blocks, T-wave inversions, Q waves, or QT segment, PR segment prolongations. And they can appear in stages, first ST deviations, followed by T-wave inversions and QT prolongations, and resolution of the changes. Then echo features, Echo features, the typical variant that is seen is the apical ballooning, that is apical akinesis or dyskinesis with basal hypercontractile segments. So there are several anatomic variants that have been described. So A and B is apical ballooning, and C, they show the Japanese octopus trap, and Takotsubo cardiomyopathy has got its name from this. And D and E are the basal variants. F and G are the mid-ventricular variants, and H and I are the focal variants. But most common is the apical ballooning variant. So modified Mayo Clinic diagnostic criteria. So they say that a patient with transient hypokinesis, akinesis of the apical apical myocardium, most probably triggered by stress. That's one point. And absence of obstructive coronary disease on angio, and new ECG changes with elevated troponin levels, and absence of pheochromocytoma and myocarditis. So this score, the InterTAC diagnostic score, helps us differentiate patients clinically from Takotsubo syndrome and an ischemic syndrome, and it helps us preventing patients from going ahead with an invasive investigations. So they use 5 clinical and 2 echocardiographic uh, factors to calculate the score. Higher the score, more favor in Takotsubo. So the diagnostic algorithm, when the patient presents to us with features of ACS, we go ahead, do an ECG, echo, and invasive angio. And if that is positive, then it goes in favor of our atherosclerotic diseases. But if that is normal, then we go ahead, do a MRI, And if there is a non-infarct pattern, then it goes in favor of a Takotsubo cardiomyopathy. So differential diagnosis. So it presents exactly like a myocardial infarction, type 1, 2, and Minoka, that is non-obstructive coronary arteries. So one difference in the clinical features is this is always and almost triggered by a stress factor. And type 2 MI, they will have features of, imbalance between supply and demand. And type 1 MI patients will have typical cardiovascular risk factors. So ECG changes are similar. Blood tests. One difference between Takotsubo and type 1 MI is the ratio of the BNP to the troponin is higher in Takotsubo. Like the failure symptoms are more in Takotsubo, and troponin levels are markedly elevated compared to the BNP in type 1. And in MI, there is a territory-based regional wall motion abnormality, which is not there in Takotsubo. And angiography is normal in this, and it shows obstructive coronaries or non-obstructive in Minoka. And MRI shows a non-infarct related pattern in Takotsubo and infarct-related late gadolinium enhancement in MI. Then management pathway of Takotsubo. So the patient presents with heart failure. So heart failure therapy with diuretics, NTG. If the patient has LVOT obstruction because of MR, then consider IV fluids, beta blockers to control the heart rate, and LV assist devices. But avoid diuretics and NTG and IVPs in these patients with LVOT obstructions. Then if the patient comes with shock and pump failure, one thing that has to be remembered is do not use catecholamine inotropic agents. Use non-catecholamine agents like levosimendan to improve the blood pressure in these patients. And LVSS devices can be used. Arrhythmias. So manage arrhythmias as routine. And if because of the LV dysfunction and stasis, they have a high risk of LV thrombus and thromboembolism. So anticoagulate these patients effectively for 3 months. And just before discharge, consider adding the patient on antiplatelet and statin therapy if at all they have coexisting coronary artery dysfunction. And if they have LV dysfunction, anticoagulate them and assess for thrombus using an echo, and treat the reversible risk factors. So prognosis, in hospital mortality can be up to 5%, and most of the deaths occur because of shock and cardiac arrest. And LV recovery is very good. The prognosis is good, occurring over 1 to 2 weeks, but it can go up to 6 weeks, and the recurrences are quite common. In a year, it is about 2 to 4%, and in 10 years, it's about 20%. Thank you, sir.
Thank you, Kirtana. Very important topic, brief topic, but it can develop in any of the critically ill patients. I think most of them you covered. I think for an exam purpose, theoretically, I think this should cover. But more or less, the new pathophysiologies have coming up in the Takotsubo, like acute catecholama and such. There are a lot of developments coming in the theory also. I would just ask the students to go through them, and the latest pharmacological therapies also maybe just before an exam, and the role of imaging like a cardiac MRI, those things, please have a watch it. Rest of them, I think nothing much. We'll go to the next
Yeah,
topic.
Yes.
we can move on to
Yeah.
next topic.
So ventricular arrhythmias in ICU. So we are all aware of this diagram. I think I'll skip this slide. So what is the mechanism of VT? So either it could be because of an abnormal impulse generation or an abnormal impulse conduction. So abnormal impulse generation because of increased automaticity or a triggered activity. And a triggered activity could be an early after depolarization and delayed after depolarization. And this is basically on which part of the refractory period does the arrhythmia get triggered. And abnormal impulse conduction is mainly the re-entry phenomenon. And this is the ring model of the re-entry. So when there's a myocardial scar, there is a re-entry that occurs around it that can lead to arrhythmias. So the causes, we can always divide it in a systematic way, like hereditary, acquired, and other causes, and drug-related causes. So hereditary causes like long QT syndrome, short QT syndrome, Brugada, early repolarization, and polymorphic VT secondary to a catecholamine surge, and acquired channelopathies, and also drugs that can prolong the QT interval, and other things like dyselectrolytemia, hypothermia, hypoglycemia, and systemic diseases like SAH, stroke, and MI. And I think we're all aware of this algorithm, the ACS algorithm for management of cardiac arrest secondary to asystole and a VT. I'll skip this slide. Next, mechanisms of arrhythmogenesis in an electrical storm. So what is an electrical storm? So if there are more than 3 VTs in 24 hours, that is called an electrical storm. So how does this form? So you require a substrate that is either a channelopathy or a myocardial scar secondary to a previous MI, along with a trigger. It could be ischemic trigger or a heart failure, inflammation, drugs, or electrolyte derangements. In addition to the autonomic dysregulation, that is sympathetic overactivity. All these things can lead to the ventricular arrhythmia, secondary to re-entry or after depolarizations, early and delayed. So with an ongoing physiological stressor, it can lead to electrical storm. So this is a global approach for evaluation and management of an electrical storm. So whenever you identify these patients, a few of them are already on ICDs. So you first look at the ICD, do an interrogation, how many shocks, how many episodes of VT were there and how many shocks were given, and try to optimize those settings. Or if the patient is not on an ICD, place external defibrillator pads and do a thorough hemodynamic assessment, and identify all the triggers and send for appropriate lab analysis, and do a cardiac assessment using an echo, and ischemic evaluation by doing an angio. So if not, then optimize the ICD settings and risk stratify the patients before taking them up for a catheter ablation. I'll describe about this score in the next slide. So then there's a stepped care approach to a patient who has VT storm: anti-arrhythmic therapy, anti-adrenergic therapy, sedation, anxiolysis, and hemodynamic support. I'll talk about this later. And next, you also have to look for the substrate, like is it a scar or so that's why we can consider a cardiac MRI and look for old ischemic changes or ischemia related patterns, and also assess for hemodynamic support using our ventricular assist devices. So if this is successful, go ahead with a catheter ablation. If not, go for transplantation or palliative care. So this is the pain SD score, where they evaluate patients, like who are the patients who can go for a decompensation during the VT ablation. So they assess these factors like pulmonary disease, age more than 60, ischemic cardiomyopathy, NYHA class 3, 4, ejection fraction less than 25%, or a VT storm, and diabetes. So if the points are more than 15 to 17, then this patient has a high risk of decompensation during the VT ablation procedure. Next, this is the stepped care approach, step 1, 2, 3 of antiarrhythmic drugs, adrenergic blocking, sedation, anxiolysis, and hemodynamic support. So if it is a low risk patient, we directly go ahead with the step 1, that is oral beta blocker therapy, amiodarone IV or oral, and benzodiazepines, sedation. No, if the patient goes for recurrent arrhythmias, then go on to the step 2, that is add-on therapies. You add a beta blocker, you add lignocaine IV or dexmedetomidine for sedation. In spite of this, the patient has recurrent arrhythmias, go for rescue therapies. That is to prevent, to inhibit the catecholamine surge or the sympathetic surge. You can do a stellate ganglion block, or IV procainamide can be considered. But procainamide is generally contraindicated in patients with heart failure, structural heart diseases. So precaution with that. And go ahead with general anesthesia and sedatives, either anesthetic infusions. And urgent ablation has to be done. And definitive therapy is catheter ablation